So yeah, warmly welcome to everyone. Thank you for coming. Thanks, Brenda.
Okay, brilliant. So I'm going to introduce a little bit about the role of AHPs in neonatal care and our best practice guideline. For some of you on the call, this information you'll have heard before, but I know there's a wide variety of people on the call, so we'd like to just run through a little bit about the changes that have taken place within the role of AHPs within neonatal care over the past 3 to 5 years in London, and also talk through why we developed the tool, what it looks like. And at the end, I think we're going to hold questions until the end. Kerry, is it? Remind me.
Yeah, that's correct.
Yeah. So if you can all see up on the screen there, is the start of our presentation. So just to introduce myself, I am Brenda Carty. I'm one of the lead allied health professionals for the London Neonatal Operational Delivery Network, and I'm one of the lead speech and language therapists. So thank you for coming today. We want to introduce the idea of our neonatal best practice guidelines, which focuses on the role of allied health professionals, psychological professionals and pharmacists throughout the London neonatal workforce. And it's in line with the work that has been published by the Neonatal Critical Care Review and the changes that have taken place. Okay, can we move to the next slide, please? So one of the things that we want to focus on is we've developed this best practice guideline, and it was really to look at what the Neonatal Critical Care report and several other reports said about the multidisciplinary work. So really what we want to do is think about how we are facilitating the flexible, skilled, resilient workforce, improving quality and outcomes, fostering collaboration and at regional system and regional levels, and using multiple sources and strategies to address health inequalities. So really in line with the 10-year plan by the NHS England, who will become something else soon, it's attending to the 3 shifts, which is around preventing the need for admission, improving digital transformation and moving care into the community. So we're really looking at this workflow force plan to also be within neonatal care as well. So if we move to the next slide. For anyone new to managing people or new to the neonatal workforce, we're really looking at this is the key body of people that are involved in neonatal care. So you've got the baby and the family at the heart. And previously models of care really looked at caring for a baby, you know, was very much about getting them well, getting them home. We've moved more to a model of care based on the Neonatal Critical Care Review and several other reports around caring for a baby early or sick requires a team. So we're really looking at how we set them up well to go forward and how we can improve care and outcomes. And as you can see, you've got within that all part of the team include your medical workforce, your nursing workforce, your admin workforce, but also your allied health professionals, psychology and pharmacy workforce. So this really embodies that we're not on the outer, that we're within the team. And that's the way the shift has gone. We move to the next slide. So previously, especially as someone who worked with the neonatal care on neonatal units, it was very much an access to model from the Department of Health toolkit, and we've moved really to an embedded model of care. And over the past 3 to 5 years, we've really looked at the different roles of the allied health professionals on neonatal units. And so I'm not going to read them all out, but this is what we're looking at as what your neonatal professional from the different professions will work towards on a neonatal unit. So has moved away from an ad hoc model of care to a more neurodevelopmental and responsive role, and really underpinned by all of the key frameworks, which include family integrated care, developmental care, BIS and BFI, the Baby Friendly Initiative. And that's what we're working towards, and that's what we see as our neonatal model of how professionals are working on units. We could go to the next slide. So one of the things that we also have shifted in terms of our focus is around when allied health professionals, psychologists and pharmacists get involved. So it's every step of the way. So it's thinking about the antenatal or the prenatal admission, the early admission, throughout the admission, supporting discharge and post-discharge. And we're thinking not just about the medical care, we're thinking about all of those elements of feeding and lactation, communication, mental health, well-being, posture, tone and movement, and all the other little things in that purple box in the corner. So it's really shifting to a model of care that's from start to finish and post-discharge. Next slide, please. So we've really looked over the past couple of years at how we deliver models of care within neonatal care. And so your allied health professionals, psychologists and pharmacists are all working towards the model that you see in front of us, which was adapted from Marie Gascoigne's model of care about integrated workforces. So what you can see here is previously the main model of care that was being delivered by allied health professionals, psychologists and pharmacists into neonatal units was around the specialist care. So that was the idea that we would get involved at the point that the medical nursing team felt that we could get involved with the more highly complex infants to support the care when needed. So we've moved away from that because we know it's a highly complex area, and we're looking at AHPPPs been involved at every step of the way. So it's looking at the universal models of care that can support the baby and the family during their admission to discharge and beyond. So that's looking at embedded models of care for all. So baby friendly initiative, the family integrated care initiative, developmental care and neuroprotective care. And this is the framework that will be used in our best practice guideline. So there's more of a focus now on preventative care and providing therapeutic input for the at-risk populations, as opposed to just the specialist populations. So that's things like specialist ward rounds, supporting and screening infants at risk of neurodevelopmental outcomes, and then the specialist care plans as well. So this is the model of care that we're using throughout London and nationally as well. Next slide. So really and truly what we're looking at is not just getting babies home, it's improving outcomes throughout the journey and post-discharge. I'm not going to read the quotes, but there's some powerful quotes there. It's not just about doing the right thing for the family, it's also about what is cost efficient and right for the family. And it's developing care that is holistic to all of the neurodevelopmental, nutritional and psychological outcomes of the family and the baby. Okay, next slide. So there's lots and lots of directives out there that we're aware that we're working towards. So I mentioned the neonatal critical care review. We've got the 3-year maternity and neonatal plan, the 10-year plan, the operational planning guidance for 25-26, the Embrace, the Ockington and the Kirkup, and the current maternity and neonatal investigation inquiry that's taken place. These directives are talking about working towards more embedded models of care, holistic models of care, with AHPPPs at the centre of it. Next slide. So within just a quick snapshot of what our roles are, I'm not going to focus much on this because I think quite a few of you are familiar with us, but for anyone who's not. So really we're the leads for the network who are to support and grow the workforce. So we're scoping what the workforce looks like, supporting people to be creative with what the workforce looks like, and then supporting the workforce to grow and develop, because this was a workforce that was very sparse on the ground. It's to continue to come up with strategic ways of supporting clinical supervision, communities of practice and peer support. It's the clinical governance, which involves things like guidelines and best practice and ways of working. And it's the ongoing education and training, not only of our profession specific, but of our medical and nursing workforces as well. So that's a little bit about our role, and that leads nicely into why we have started to develop the best practice guideline. So before we go on to that, this just gives you a little snapshot of what the workforce looks like in London at the moment. And so obviously in the grey is what we need to get to for full staffing standards, and the green is what we have and the gaps. So as you can see, for most of the professions, the grey is the big. So there is still significant professions that are 50% and below. for the staffing standards, and that's the picture post growth with the Ockenden funding, and that is the picture post some units actually putting some money into growth. So although the professions are growing and have grown over the past 3 to 5 years, the gaps are significant. So the need to work on that and how we continue to develop as a workforce is really still needs to be a focus. Next slide, please. So what we have been doing for the past few years is scoping the workforce, developing the workforce, and one of the things that we have done is a phased approach to our stakeholders. That includes the units, yourselves, the unit therapists, and getting to know you, getting support systems in place. But also we've worked very closely with you about workforce development and planning. And one of the things that came up in our phased approach was around the development of a best practice guideline. So we've had key stakeholder involved at every stage from all of the professions, and that started in 2023, where we took consultation, what people would want in a best practice guidelines, discussion with each of the professional groups, and then we put together the best practice guideline over the past 18 months, which has then gone out for consultation, and it is now the piece of work that we have finished. Next slide. So really, this is just the contents, because I'm going to talk through a little bit about what the guidance is, but really it looks at the purpose of the document. It describes the London context, and then it goes through each of the allied health professionals, psychologists, and pharmacy care, breaking it into models of care, and then each profession specific. And we have a set of appendices as well that goes through different documentation as well, including transitional care and outreach. If we move to the next slide. So what is it? It's a bespoke guide for London. It's a description of best practice for fully staffed services, but it breaks it down so that you can use that for a range of needs, which we'll talk a little bit more about. It's guidance not only on what you need in terms of staffing recommendations, but what SLTs, physiotherapists, occupational therapists, dietitians, psychologists, and pharmacists should be doing when they're on units. And what it does is it uses that model of care that we talked about at the start, with the universal, targeted, and specialist, and it maps out for every allied health professional and profession specific what you should be doing at each point. Okay, next slide. Wait, did we miss one there? No, we didn't, sorry. So how does it help? So being able to look at what is your staffing recommendation, but also to be able to record what is been done and what isn't been done, not only supports job planning, business cases, but improves quality of care, because we're working towards best practice. The guideline outlines the best models of care and the most up-to-date evidence-based practice, and it ensures a governance over the AHPPP rules, because there is a variation in what is happening and what our people are working towards because of the changes in care over the past few years, and because it's an evolving workforce as such. So we want to reduce the inequality by working towards the equitability care across all units, with at each time, because the models of care focus on those family models, such as BFI, such as FI care, such as trauma-informed care. We're thinking about empowering families to advocate for what they need. So we're also looking at a new way of working in neonatal units, that we're focusing on early intervention as the mode to improve long-term outcomes. And this best practice guideline really focuses on that. Next slide. Okay, so these are just some quotes from our parents on the unit that really highlight what it is we do as a group of professionals to support our parents. And I think a lot of the time it is parental quotes and the parental experience that really is what we want to keep at the centre, and the difference that we do make to their journey, but also the outcomes later. Okay, so just to finish us off, we've got a little video about the role of allied health professionals on the neonatal unit, just for anyone who hasn't seen it, and anyone who's newer to managing someone from AHPPP.
This year, 10,700 babies were born needing neonatal care in London, and approximately 56% will have additional needs requiring AHP and psychology support. To reduce the future cost impact to the NHS and our education system, our neonatal population need ultra-early intervention to minimise the impact of prematurity and medical conditions on their development.
We need to act now.
We need to act now.
We need to act now.
If you needed care on a neonatal unit like me, you might need some extra help from other team members.
AHPs work together to provide holistic, family-centred care, and this support is vital for parents, babies and professionals.
The shock of having a baby arrive in the NICU can be overwhelming, but this was lessened by the dedicated professionalism and care of the team. I was unaware that this wasn't a standard practice or consistency throughout the UK. I would say that without it, I don't think he or we would be in a situation to have come home in the way that we did.
It really changed my experience because I stopped seeing hospital as a place where my baby is treated and started seeing it as a place where my baby lives and grows. The hospitals that are considering to have more AHPPs should definitely do this, because this means better experiences for parents and more holistic care for children.
The health professionals we worked with, some of them were fantastic, and you know, they've really had a beneficial impact on our daughters and our lives. But on the flip side of that, we also had to really fight to get that sometimes. And this really shows to me a bit of a disparity, an unfair disparity really, that based on your postcode and where you live, you either get kind of world-class support or almost no support, and it's a massively stark difference.
We have to have a holistic approach to neonatal care, and nurses, doctors, allied healthcare professionals and parents all have a very important role to ensure that our vulnerable preterm babies can have the best possible outcome.
If you haven't worked yet with AHPs, you should get familiar with their role, and you will soon realize that together we can do great things for our babies and families.
We need to act now for them.
Help children like me have the team that they need from the very beginning.
Brilliant. That's great. So that's my bit done. I'm going to hand back over to Kerry, who's going to talk us through what we're going to do now.
I think we have Mo up next with transitional care. Thanks, Mo.
It's Kerry. Hi, everyone. For those of you who don't know me, my name is Maureen Mustafa, or you can call me Mo. I'm the lead dietitian for the London Neonatal Network. And I just wanted to spend a little bit of time with you explaining what transitional care is and why we have talked about it in the best practice guide, because it's still a bit of an unknown area to a lot of certainly managers who are looking after staff who work in neonatal units. So in 2017, the British Association of Perinatal Medicine, or BAPM, produced a framework for transitional care, or TC, and they came up with a definition which says that neonatal transitional care, or NTC, is care additional to normal infant care provided in a postnatal clinical environment by the mother or an alternative resident carer supported by appropriately trained healthcare professionals. So you'll notice in that definition that it doesn't stipulate a specific neonatal environment or postnatal environment, and that was intentional. TC is considered a service rather than a location. So across the country, across London even, TC looks different and is carried out in different settings. So in your hospital or trust, there may be a dedicated TC ward, or it may take place on the postnatal ward. The service may be run by the neonatal service, or it also could be run by the maternity service. I think that regardless of the setting and the primary service that is running it, we want to emphasise the importance of appropriately trained professionals supporting the mother or carer, as it says in the BAPM definition, and that can and does include AHPPPs. So as network leads, we are often asked what role AHPPPs play in TC, and that is why we added these specific appendices. I'm just going to share my screen. So if you download the, if you have downloaded already the best practice guide from the website, this is from page 71. So in the appendices, you will find profession-specific guidance on how we as AHPPP support families in transitional care. And you'll find in this guidance advice and information around what it looks like to identify specific infants that need input from AHPPPs in transitional care, and it follows the same sort of setup as you'll find in the main body of the best practice guide in terms of the coloured traffic light system. And it will also illustrate required skills and competencies that the AHPPPs working in this area will need in order to deliver care to families in this area. So we've done dietetics, and there's occupational therapy, and going a bit too fast, there's speech and language. So all professions are covered, including pharmacy as well. So I'll stop sharing and I'll hand back over to Kerry. Thank you very much.
Thanks, Mo. Next up, we have Millie going to give us a bit of an outline of the breakout rooms.
Hi, thanks, Kerry. So yeah, just quickly, for those of you who don't know me, I'm the joint lead physio for the London ODN. So what we thought would be quite useful to do today as part of this workshop is to get into small groups of, I think we're going to have about 5 to 6 people, and just to give you guys a bit of a chance to kind of discuss amongst yourselves how you think the best practice guide might be useful on your unit. So kind of as Brenda sort of touched on, we kind of envisage the document being used in lots of different ways depending on kind of where your unit's at. We understand, and it's kind of written in the document, the challenging financial situation at the moment in a lot of trusts. So we're not kind of automatically thinking we're all going to be making business cases for new staff and things like that. We hope this could be useful if there's an opportunity to do that at some point, but we're also thinking about how we can use it for things like job planning, kind of mapping our services, thinking about how we can kind of utilise the staff that we've got, the AHPPPs we've got working on neonatal units, and how we can utilise that best. Thinking about quality improvement, competencies and induction and pathways. So there's kind of really a lot of ways that we can envisage this document being useful for the AHPPPs on your units. So Ellie's gonna put you into breakout rooms. We're just doing kind of random mixes of, like I said, 5 to 6 people, and we'll give you about 20 to 30 minutes, and we'll give you a 5-minute warning. Amazing. Thank you. Yeah, I think that's a really good point. Even if we're not kind of at the stage to be kind of submitting a business case kind of there and then, I think, and we've talked a lot about kind of workforce plans and things like that in our kind of phased meetings. So I think that's really important to kind of just use that document to have that ready if and when that opportunity comes up. So yeah, that's great. Thank you. So group 2 was the group with Fran Crosby in it.
Yes, I think a couple of things we were talking about, job planning at the beginning, helpful to have that document to go to. And then Alana, you mentioned one issue that was close to you, I think, was around the estates and mentioning of what we needed to deliver those services and making sure that the environment is fit for our staff. Yeah,
I think that's a really good point. I think space is a massive issue, I think, on a lot of units, but I also feel, and this is from kind of experience clinically and things as well, that having that space makes your team embedded and gives you the opportunity to actually be embedded and have that kind of model. So that's really great if you could kind of use that document to support that. Thank you. The third group is Joe Harrington Hill.
Yeah, so we had so many points. Where shall I go? We were talking, I guess, one that hasn't been mentioned, a guide for the team about what to prioritize, what kind of parts overlap between different professions and potentially what parts don't, but also it's in supporting well-being of staff. So helping them realize that they don't have to provide all of this if they haven't got the full staffing, and what areas to prioritize.
Mm-hmm. Absolutely. I think that's a really, really good point. So kind of not necessarily thinking how can we immediately up our workforce, but thinking kind of like you said, how we can use what we've got and the resource what we've got to prioritize. And I think well-being as well is such a massive point, and we really hope that this document will be helpful for that, and Ellie's going to touch on that in a little bit more detail after this. So yeah, that's great, thank you. And then the next group was Natasha Mead, your group.
Hi, so most of the group I was with, we were actually people not working specifically in neonates and often with adult backgrounds. So actually this was a really helpful document, we felt, so that we could get a better understanding of, you know, what our staff are doing or aiming for to be able to support them. And then I think our only other kind of comment was really just, given, dare I say the word, finances, is how we build those cases and that business to kind of get to where we want to go, which I think we all appreciated is just currently a bit of a challenge.
Amazing, yeah, thank you. Yeah, really good points. I think a lot of therapists, AHPPPs, are managed by managers who aren't necessarily working in kind of even paediatrics, neonates. So yeah, that's a really good point, that can be really helpful for those you guys who are those managers. Thank you. Okay, so next group 8, Zoe Berger.
Actually, I think Ruth's going to feedback for us.
Okay, go for it.
Hi, we recognised the moral distress surrounding the gap between what this document tells us is best practice and what we know is the available resource, and the importance to kind of wellbeing and recruitment and retention to acknowledge that, be real about it, and to mobilise the document to prioritise and be creative about about how best to implement it. We had a question about whether in workforce planning under psychological professionals, mental health nurses might be included. That's a personal bias from me as a mental health nurse, because we often have perinatal experience and are used to working in an acute setting, and we also wondered about how this document links with best safeguarding practice.
Thank you. Yeah, some really good points there. And I think, like you said, about kind of acknowledging those staffing gaps. And, you know, we can really see that from what Brenda said in the kind of presentation with that table, is really important. Do you mind if we just hold on to the questions, because we've got a little bit of time just at the end to hopefully to answer a couple of questions. So if that's all right, just hold on to those 2 questions until the end. That would be great. Thank you. And then last group is Katie Strudwick, your group.
Hello, anyone from the group jump in. We were talking about, well, loads of things really. Yes, the gap in staffing, the difficulty around business planning when we know the financial position doesn't allow for that at the moment, and but how it can be a powerful tool to try and get short staffing on a risk register. So from a governance point of view, we are a bit safer, and we have highlighted the need, and we can reference it at review meetings and exec board meetings, etc. So it's not solely us, and hopefully certainly not our staff, holding that risk by themselves. We talked about the power of having a document like that to help colleagues who perhaps haven't had exposure to working with AHPs in the past recognise the strength that we can bring to a robust and holistic service. And I don't work on the neonatal unit, but from the conversations that I've had with the fantastic OTs in our team at Evelina that do, there's been a real shift in recognising what we can offer and the difference that it will make to the babies and the families that are on the unit, from colleagues that perhaps hadn't seen that before, because unless you're there doing the work, it's kind of invisible. So it's been really powerful in terms of being able to demonstrate that and then build job plans and services around it. So
thank you, Katie. Yeah, I think you're absolutely right. I think there really is a role for the document to kind of really show the value of AHPPPs on the unit, which is sometimes quite hard to kind of show the kind of longer term outcomes and impact on families and things like that. So I think that will definitely really help. Amazing. Well, thank you all so much for that. I really feel like that covered a lot of different ways that the guide could be useful. And hopefully it's made you guys kind of think a little bit more about how you can use it in your units. So I'm going to hand over to Ellie now, who's just going to go a little bit more into the kind of wellbeing side of things.
Thank you, Millie. Thanks, everybody. That's a really really encouraging start. We were talking at the beginning about we weren't sure how aware of the document people would be, and are aware that some of you will have had time to read it and others really won't have done. But we wanted to spend a little bit of time thinking about how we support the workforce, because that is a key part of the role that managers have when they're supporting AHPPPs delivering a service on a neonatal unit. And we wanted to make the point, as has been really well made from that feedback, that this document has many uses.
I think somebody has said there's a group that missed. Or are they okay for us to just keep going? That's fine. It's just in the chat, one of the groups were missed, but I think they said all the points were covered.
Oh, great, thank you.
Sorry, Hannah, I have just seen you on my list. Sorry, my fault.
Okay, I'll carry on. So we hope that this document will also support in supporting the workforce, and that picks up on the point that Ruth was making a minute ago about the moral distress around recognising where the gaps are, and I'm going to talk to that a little bit. But first I wanted to just make the point about how vulnerable our workforce is. So all the data we have about staff that work in intensive care across the specialties, not just neonatal, but also PICU and adult intensive care, we know that they're a really vulnerable population. They have the highest level of stress of any of the populations when they're consistently surveyed. This data is actually from PICU, but I think it's similar enough that we can extrapolate that data and bring it across to the neonatal context. And what that data showed that Gillian Colville looked at was that 40% of staff working in PICUs have one or more of the following: burnout, moral distress, or post-traumatic stress at diagnosable levels. So there's reason to be concerned about the population. And that includes, this study did include AHPPPs as well as nurses and medics, and it just backs up the other findings that we already have. We also know that our populations, a lot of our allied health and psychological professionals and pharmacists are setting up new services where there haven't been one before, developing services, growing their workforce, and that is also quite a stressful piece of work to be doing. Additionally, if you think about the current context in which we're working in neonates, we've had over the last few years the Neonatal Critical Care Review, which really called us to develop specialist services in a much bigger way. Then we've had Ockenden looking at the failures at Shrewsbury and Telford, some of which were catastrophic. Then we had Kirkup looking at East Kent, again, significant issues there. There was another Ockenden in progress. Then we've had the Lucy Letby inquiry, the Thirlwell inquiry, which is going to publish soon, but is now being held off because of the National Maternity Inquiry. So there's this huge threat in the system coming nationally and feeding downwards to us, and that's putting pressure on everybody. And if you kind of put that into the mix with the threat that's already there from very sick babies and very anxious parents, our staff are right in the middle of that threat sandwich. Essentially, they're feeling threats coming up from the bottom and threats coming down from the top, and it can make working on a neonatal unit quite a difficult thing to do sometimes. I think the current context is particularly difficult around the inquiry, not knowing which hospitals will be picked for that inquiry. And one of the things that Bill Kirkup said in his East Kent report is we have to stop doing the same thing and expecting we're going to get a different outcome. Actually, we have to start thinking differently. And that's one of the things that we hoped this document would do. If you're interested to read more about that, I've put a QR code there to a comment about the most recent threat that got injected into the system was the arrest of some NHS staff around the Canchester Chester, that's the hospital where Lucy Letby worked, and some kind of thinking about the way that that impacts on staff. I would really recommend that. I'm going to move on from this slide, but I'll put that QR code in the chat at the end in case you're interested to read it. So we recognise that there are no quick fixes, and one magic document like this one is not going to do everything that we'd like it to do. I think any intervention that attends to the multiple threats in the system and the ways our workforce are stressed, it is going to need lots of pieces to put together some sort of consistent, holistic package of support around our staff teams. I think the first and best thing that we can do is pay attention to the little things, which actually are the big things. Things like making sure that people get their breaks and people have, you know, a drink while they're working. All of those really basic things, that they feel safe to work, that they can report complaints when they need to. A lot of those things were picked up in the Ockenden and Kirkup reports, but I think we forget those things at our peril. So we're absolutely not saying this best practice guide is the magic answer to all staff stress in neonatal units. We're saying it's one of the pieces that goes into thinking about how we look after the well-being of our teams. So how do we think it might do that? Well, I think I was really pleased about what Ruth said earlier, because I think the first is we'd really like to name what a big job it is to deliver any of our professional roles on a neonatal unit. It's not a could you just pop in and do this thing. There's actually a lot of work involved in delivering that, and we cannot deliver that on the levels of whole-time equivalents that we have at most of our units at the moment. It's difficult to be able to deliver a full service when you don't have full staffing. And being able to really clearly name that feels really important to us. And I think that I was thinking as you were talking, Ruth, there's something about control, that we know that when we feel more in control of the challenges we face, we're better psychologically, we're better able to kind of navigate them. And I think what we hope this document will do is give a little bit of that control back, because it gives you the ability to articulate about what you can and can't do with the provision you've got. So we would really encourage you to use this document to name what provision you are able to provide on the amount of staffing you currently have, and to acknowledge that that is not enough and that it feels quite uncomfortable to not be able to deliver some of those things, and to be really clear, both to start with in your conversations with the people that you manage, but then also obviously in conversations onwards with the units about what can and can't be done with that level of provision, and what challenges that throws up, and what dilemmas need to be kind of faced around what can we and can't we deliver with this. And I think that ability to name it, if you think about when we were all much more junior and starting out, it was difficult to even articulate why we felt like we were doing a bad job, and to be able to kind of make sense of how we delivered something that felt useful, to be able to have that conversation with your managers in a really clear way, looking at the best practice guide and taking those bullet points that are under each of the headings under the universal, targeted and specialist, gives you the opportunity to say, can we deliver this? Is it possible? Which out of these ones can we and can't we deliver? So I would don't shy away from those conversations. I think sometimes we tend not to because they're uncomfortable, but actually being able to talk about that, and then move the conversation on to, so what can we do? And then what do we need to do about the things we can't do, feels really important. And then we would really encourage you to think about job planning. For allied health professionals, there is a brilliant job planning guide on the NHS website. I've put a screenshot of it there. For psychological professionals, the BPS guidance is good, and our staffing standards has some guides on job planning as well in the appendices. So I would look at all of those documents, and then use those to help you think about how much face-to-face delivery of these bullet points do we want to be doing, how many of those things aren't possible to fit into the week. And I also think it's helpful for goal setting. I was thinking as I was writing this about how different graduates coming out now are to maybe people towards the end of their career, different expectations, different kind of desires about the way that they engage with work and their own well-being, for example. And I think being able to be really clear about goal setting, about this is a service we'd like to provide and we think this is reasonable on the whole-time equivalent that we have, excuse me, I think is a really useful conversation to be having. So I think it can be used to empower managers to support developing the provision that is reasonable within that time. And I think it can also be used to empower our therapists to think about what they feel is manageable and to have those collaborative conversations. And I just thought I'd end with this quote, which I really like. I think it isn't easy. The context in which we work is not easy for all the reasons I've just laid out, because we work in a very cash-strapped NHS. The current context of the NHS is quite difficult. We know that even though we could identify gaps, it may be difficult to get additional posts funded. I say difficult, possibly impossible currently. And I think that as managers, therefore, we need to approach some of these conversations with real compassion around how we can inspire the people that we are leading and asking to deliver a service in a way that feels doable to them and also feels enough for the families that we're working with. And that's me. So I'll be around at the end to answer any questions, as will everyone else. Thanks.
Thanks, Ellie. And we'll now have an opportunity to take any questions. We'll monitor the chat. So you're welcome to post any questions in the chat or just raise your hand and we will hopefully be able to answer some of them. Any questions about the guide or anything that any reflections or anything we've covered today? Bruce.
Thanks. Just going back to the questions from earlier, what are the thoughts and reflections about mental health nurses being included in psychological professionals, and also what is the role or the guidance? How do we make the guidance fit with safeguarding as well?
Really?
Yeah, it's a really good question, Ruth. So our the staffing standard for psychological professionals lays out that our minimum staffing should be 1 per 20 cots as a minimum of clinical or counselling psychologists and child and adolescent psychotherapist. I think in units where we've got those minimum standards, which is currently nowhere in London, additional resource could then come from people like mental health nurses. I absolutely agree with you that they bring incredible expertise to be able to support families in different ways. There isn't currently, as far as I'm aware, any plan to revise those standards to include mental health nurses. But like I say, I think they could be a part of the picture. And in fact, there are places, we do have units where not mental health nurses, but bereavement nurses are offering some of the provision. So I think they're a vital part of the team that supports the wellbeing of families. In answer to your safeguarding question, can you be a bit more specific about what you're thinking there?
Are safeguarding professionals, as in safeguarding midwives and so on, included in the AHPP offer, or is there a set of guidance that we can reference to ensure that when we're delivering best practice as managers, safeguarding is factored in all along?
So this guidance only covers the allied health professionals, so pharmacists, psychological professionals, and then OT, physio, speech and language, and dietetics. So it doesn't cover nursing, and there will separate guidance for nursing would need to be looked at. I'm not as aware of that. In terms of safeguarding more generally, those would be guiding principles that would absolutely cover all of our professionals. They're all part of our HCPC registration. So we would expect all professionals. I don't know if my HP colleagues have anything to add to that, but we would expect all professionals to be following the rules they would normally follow and working in the way that they would anyway. And I would see that part of that was being involved in things like ward rounds where safeguarding is discussed would absolutely be key, and we would have built that into there's in the best practice guide, there's a section for each profession, but there's also a generic section that all allied health professional psychologists and pharmacists should be doing, and it talks a lot about the generic skills around building relationships with families, a bit like that slide that Brenda showed that had the 5 kind of coloured rectangles, and then it had some little blue ones, because there are some skills around building therapeutic relationships, for example, that we would see all AHPPPs being involved in, and I would see safeguarding as coming as part of that.
Thanks, Ruth. Mo, I see you have your hand up.
Yeah, I was just going to add, I mean, like Ellie said, I mean, safeguarding training is mandatory for all staff, and particularly those working with children and neonates. They were expected to do their safeguarding for children every few years. You did mention safeguarding midwives, and again, this document doesn't cover perinatal services. It's very much neonatal services, but I do think it's something to highlight and certainly think about a bit more. You know, a lot of the drivers that Brenda mentioned in her presentation, such as the Ockenden Kirkup 10-year plan, they talk more and more about obstetrics, perinatal medicine and neonatal services coming together and working as one team. The British Association of Perinatal Medicine, BAPM, who I mentioned when I was talking about transitional care, they often write frameworks in terms of what we use to support why we're doing what we're doing. And they do have one for neonatal staff, but maybe they're a group to approach, because they are very much trying to promote that one team working across perinatal and neonatal services, in terms of if there is guidance out there in terms of staffing for midwifery, those special quality roles, and making sure that the whole team is looked at holistically rather than keeping us, you know, in silos. So maybe that's something to think about for all of us to think about.
Thanks, Mo. Any other questions? Ilana?
Maybe quite a practical question. I was just thinking, obviously, we can all support using this document and reference it as needed within our roles. I was wondering a little bit about how it's already being distributed, via what channels, or where it might be distributed in future. It feels really helpful, and I guess more people who are aware of it, the better.
Brenda, was that to answer Ilana's question?
Yeah, I'm happy to try and answer this, and if that's useful. Do you mean in terms of how we've launched the document regionally? Is that what you mean, Ilana?
Yeah, exactly. Because it feels important that multiple stakeholders are aware of it, and we can also help with making people more aware of it.
Absolutely. So what we've done, we've been, as a group, we've come together with our director and a small working party of us, and then the wider group have actually been involved in the best practice guideline launch, and this is just one of many meetings that we have launched. So we have systematically reached out to all of the LMNSs and requested attendance at those to go through the document with the different sector LMNSs. We've also reached out to the BCYP regionally across London, and we've also managed to secure a slot on each of those. We have also had a slot on the senior nursing, neonatal nursing regional meeting. Please correct me if I'm wrong. We've also at the clinical oversight meetings, which will be all of the neonatologists, the LNG, and we have also launched it, let me see, at a profession specific. So each of the professionals on the group have also taken it to their profession specific or are about to, and disseminated it that way. Additionally to that, it has been formally sent to Philippa Wright for the AHP Director of NHS England. And it has also been, please jump in here, Ellie, it has been sent to NHS England. Do you want to talk a little bit about who we disseminated to for NHS England?
Yeah, so we've sent it to basically everybody who's high up in neonates and NHS England, the people who run what was it used to be called the NIB, which was the Neonatal Implementation Board, which implemented the Neonatal Critical Care Review, and it's now called something else that I can't remember. But we sent it to, say, for example, the chief clinician, the lead nurse nationally for neonates, and a few of the other people who have kind of strategic organisational roles. We already know that we've had requests from 2 other operational delivery networks to take this over and adapt it for their regions. end. And I imagine that we aren't there yet, but we always wrote this with the aim that the work then wouldn't have to be done 10 times, but would eventually become a document that everyone could use. I imagine that it will become the document that all the England operational delivery networks are using, or something, a version of it. Obviously, we've got the London context as the first chapter, and that will be changed. But I imagine if enough ODNs want to take it on, that it will just become a national document. So that's a work in progress at the moment. I know there are a few IDNs thinking about it.
Sarah?
Hi. Oh, sorry. I just was calling. Wanted to ask about whether you shared it with the community therapy kind of managers as well, just because I think obviously we're quite unusual at Hums in that we are kind of acute and community, but it might be that something, because I noticed you've got on there about band 6 rotations being a suggestion, and I think it would be really good for the community, because the community teams maybe wouldn't be familiar with this as much, and it would be a really good thing for them to know more about.
I'm happy to answer this question, Sarah. Yeah, so when we reached out to the babies, children and young people regional groups, they have attendance from all of the community managers across all of the networks, as far as I'm aware, and I've attended 2 of those already, and I've attended the NCL ones, and they have both acute and community therapists. So we've had Barnet therapy leads, we've had Whittington, both acute and community. So yes, from what I can tell, that it should be disseminated down that way. If anyone else wants to add, but yeah, that's the way we've gone in through it. I'm sure we could bring together the wider group at another point, but I think it should be adequately disseminated through the babies, children and young people, including your own managers. I have reached out to arrange a meeting with them. So yeah.
Thanks, Brenda. Are there any last questions before we draw it to a close? Doesn't look like it. Thank you so much again, everyone, for attending today. We've had an amazing attendance from you all and great engagement, so thank you. And just to encourage you to please have a look at the best practice guide when you get the chance. For those of you that haven't, I think Ellie did post it in the chat earlier today, so you could have a look at that. Otherwise, it's on our website as well. And just to encourage your unit-based therapists as well to have a look at the guide within context and see how it aligns with your unit. So yes, thank you so much. And we really appreciate you all being here today.